Hello, I'm Dr. David Henry with the Community Oncology Journal here at the American Society of Hematology meeting. And with me today is Dr. Rob Hromas, who is chairman of the Department of Medicine at the University of Florida at Shands. And we've asked Dr. Hromas to tell us a bit today about, we're nearing the end of the meeting, about the best of ASH and some of the things that were new or exciting, clinically mostly. So thank you very much for joining us. And
thank you for having me.
What was exciting?
There are a number of things that were very exciting at ASH. I think one of the most exciting things at ASH this year has been the development of a really robust gene therapy system for hemophilia B, for factor IX deficiency, using a specially modified adenovirus-associated vector, AAV vector, and intravenous infusion of this vector with the hemophilia B gene, factor IX. This virus takes up residence in the liver and produces factor IX such that hemophilia patients with hemophilia B no longer need factor replacement. So this is the first tiny step on the path to a cure for hemophilia B.
Incredible. I have a patient who will be very happy who has hemophilia B. Any hope for hemophilia A?
Well, unfortunately, hemophilia A's gene is bigger than hemophilia B, which is smaller. It doesn't fit into this new nifty vector that they're using that gets into the liver and makes factor IX. And so hemophilia A is going to be a little bit trickier, but still the principle could be applied ultimately to hemophilia A as well.
Okay. What else did you think was,
well,
that's really exciting?
I trained with Don Thomas in bone marrow transplant 23 years ago, when he was still on the wards. He won the Nobel Prize for inventing bone marrow transplant in 1990. And so I have fond memories of my time at the Fred Hutchinson. And when I first started doing bone marrow transplants, we would spend an hour, 2 hours in the operating room harvesting patients' bone marrow.
And I'm old enough to remember that also.
And about 15 years ago, we started harvesting stem cells used for bone marrow transplants given to another individual besides the patient by peripheral blood pheresis, such that we were sucking out stem cells using needles in the arm and a plasmapheresis machine, storing those and then giving them back to the patient or the related patient's family member that needed those stem cells. And so about 90% of our harvests were with these pheresis machines. Well, they did a randomized clinical trial with stem cell pheresis versus the old-fashioned bone marrow harvesting, and it turns out that bone marrow harvesting is just as good. In fact, in some ways, maybe better. It doesn't give as much graft versus host disease. So, for example, for an unrelated allogeneic bone marrow transplant, we should use bone marrow as the donor for stem cells and not the peripheral blood stem cells, because the incidence of chronic graft versus host disease is extraordinarily high with the peripheral blood stem cells, such that there's an increased mortality from chronic graft versus host disease.
And lower with the bone marrow product.
Much lower with the bone marrow product.
Yeah, the ASH newspaper this morning headline was "Back to the OR," which you probably saw. So,
yeah, I remember those long days of harvesting 100 different aspirations with Fred Applebaum and Don Thomas and many of the other Hutchinson physicians that made bone marrow transplant what it is today.
How about anything with lymphoma or myeloma that you wanted to mention?
Well, interestingly, the HDAC inhibitors for lymphoma work quite well, and there's a number of HDAC inhibitors that are about to come out for lymphoma that I think are quite effective for CLL or diffuse large B-cell lymphoma. However, when they've tried to transfer those to myeloma, they haven't worked as well. So it's very clear that myeloma is a completely different disease, and the drugs we use for lymphoma may not be completely applicable to myeloma. And so the HDAC, that's histone deacetylase inhibitors like vorinostat, are going to be effective for lymphoma and CLL, but less effective for myeloma. And I think that's several trials presented in myeloma with the HDAC inhibitors weren't quite as exciting as we hoped they'd be. Theirs might be a little tiny benefit, but it's not as great as we had hoped it would be.
And I was just going to interject, so the bone marrow, as opposed to stem cell product, would apply to transplants in myeloma and lymphoma?
Well, most of the transplants in lymphoma and myeloma are autologous transplants, in which the patient is getting their own bone marrow stem cells back. Right. We almost always do those with peripheral blood harvesting. And since there's no chance of graft versus host disease because they're going back to the own patient, The autologous transplants with in myeloma and lymphoma will almost always still be with the peripheral blood pheresis.
Okay.
Let me mention one other thing I think is of great interest. I'm a leukemia doc, and I still love taking care of patients, even as chair of medicine.
Glad you still have time to do that.
I enjoy it too much to give up. And plus, it's a great educational opportunity for the residents and fellows.
Sure.
One of the really interesting reports at this ASH meeting was the fact that Gemtuzumab might still have a role. Remember, about a year and a half ago, the SWOG trial showed that a higher dose of Gemtuzumab increased early mortality in acute myeloid leukemia induction. And so the FDA and Pfizer voluntarily withdrew the product from the market. So we really have no Gemtuzumab available for patients. And several of us leukemia docs were disappointed with that, because there is a role for Gemtuzumab in treating certain patients that we especially liked it for elderly patients that couldn't undergo full-blown Aerosine daunorubicin 7+3 induction therapy. Gemtuzumab alone could put a fraction of those patients into remission. Well, at this ASH, there was a French trial, a very strong randomized trial, AFLA 0701, I think is what it's termed, okay, which showed that taking a lower dose of Gemtuzumab given 3 days in a row, so the same total dose, but they just split it up and gave it over multiple days instead of giving it all at once to the SWOG trial, actually had a significant survival benefit, not just relapse-free survival, but also overall survival advantage to adding Gemtuzumab to 7+3 induction chemotherapy. Well, this is exciting news in that we can improve overall survival in patients with acute myeloid leukemia. And their population was elderly patients, and those are the hardest patients to put in remission with acute myeloid leukemia. But Gemtuzumab has now been withdrawn from the market.
I was just going to say, so it's not available except on a trial.
It's not available except on a trial. And so this begs the question, is Pfizer going to start making Gemtuzumab again? Now, it's a biological agent that is difficult to make, and it's expensive to make. It's not a synthetic chemical that you can make in the lab. It has to be produced by an actual organism, such as yeast or baculovirus or even bacteria, because it's a protein, and it has to be made, it's an antibody against CD33, a protein on the surface of acute myeloid leukemia cells. So it's very complicated to make and expensive to make. However, this study indicated in elderly patients giving lower doses, not the higher dose that the SWOG trial gave, which showed increase in early mortality, but lower doses, several days, 3 days, every other day, showed a distinct survival advantage.
Are any of these trials still ongoing around the country in case any of our viewers wanted to refer patients?
There are some trials still ongoing around the country. You'd have to look at PDQ, clinical trials, at the NCI website. But pressure is building. Many of the oncologists that I know that deal with acute myeloid leukemia are asking Pfizer to remake the product.
Mm-hmm. Well, I want to thank you. I've been visiting with Dr. Rob Hromas from the University of Florida, where he's chairman of medicine there at the Shands, and for sharing his time with us and all this interesting information. I'm Dr. David Henry with the Community Oncology Journal, reporting from the American Society of Hematology meeting in San Diego.